Hi, everyone. Thanks for joining. I'll be starting very shortly, maybe one more minute. So welcome, everyone. Thank you for joining us. My name is Roshanik Medipana, and I am the Director of the Housing Solutions for Health Equity Initiative, housed at the School of Public Health. Thank you for joining us on our first fall speaker series, first event of the fall, where we highlight housing research and its connections for health and health equity. For those who are unfamiliar with what we do, the Housing Solutions for Health Equity Initiative informs local, state, and national policy through interdisciplinary research on housing as it relates to health equity, as it relates to equity in health, race, socioeconomic status, and aging. Before we start, I do want to acknowledge the detrimental impacts of war on people's well-being, but also the consequences of displacement and loss of homes. More than ever, do we see the central role of a house or a home plays in providing safety, security, and status, and the consequences of having that taken away. Today's speakers will address some of those inequities by discussing how in the U.S. policies and programs have enabled gains among largely white communities through generational wealth accumulation while taking away opportunities from Black, Brown, and Indigenous folks. Housing Solutions prioritizes engaging in research that addresses housing and health equity because we do believe access to adequate housing is a human right. Today, our speakers, Dr. Hicks, MD candidate Mikaelah Johnson-Griggs, will focus on the interconnectivity of neighborhoods, housing, and eye health. The sessions will be moderated by Dr. Newman-Casey. Throughout the event, please feel free to submit your questions to the Zoom Q&A, and we hope to answer them during the Q&A session at the end. I now have the pleasure of introducing Dr. Newman-Casey, who will moderate the event. Dr. Newman-Casey is an associate professor and associate chair of research in the Department of Ophthalmology and Visual Sciences. She is the co-director of the Kellogg Eye Center for eHealth, an endeavor that seeks to improve eye health and ophthalmic health delivery through leveraging novel technologies. She also directs the Eye Center's outreach initiative to provide free eye care for all patients referred through the local free clinic, Hope Clinic. After graduating from Reed College and the University of Michigan School of Medicine, Dr. Newman-Casey completed her ophthalmology residence and glaucoma fellowship at the University of Michigan. During her fellowship, she earned a master's in health and healthcare research through the Robert Wood Johnson Clinical Scholars Master's Program at the University of Michigan. Welcome, Dr. Newman-Casey.
Well, thank you so much, Dr. Medipana, for such a lovely introduction. And I am very honored to be here as part of your inaugural fall lecture series for the Housing Equity Solutions. And I'm really honored to get to introduce two members of our lab, Dr. Patrice Hicks, who's a postdoctoral fellow in our lab and also an ARACTA fellow, who's been doing really wonderful research looking at the impact of neighborhood on eye health. And in particular, what she will present today is a fascinating exploration of how redlining, a historically racist policy of denying mortgages to Black and Indigenous people and Brown people, and really, which has led to a lot of segregation in neighborhoods that's present to today. And she's looked both at how those policies impacted the prevalence of visual impairment and blindness in neighborhoods today, and then also is looking at how current neighborhood health and resources impact people's current day prevalence of visual impairment and blindness. And so without further ado, I can't wait to hear what Dr. Hicks has to say, and hopefully you will find everything she has to say as wonderful as I do.
For my slide. Hello, everyone.
They should be there. Sorry, y'all. Let me do a new share. Hold on. Is that good?
Yes, thank you.
Sorry
And thank
about
you.
that.
Yeah, no worries. Thank you, Dr. Newman-Casey, for the kind introduction. Hello, everyone. I'm excited to be here with you today to share our work with you all. I also want to thank Housing Solutions for Health Equity for inviting me to speak today. I will be sharing our lab's work entitled Past and Present Measures of Neighborhood Inequity and Visual Impairment and Blindness. The funding for this research did not impact the design and conduct of the study, collection, management, analysis, or interpretation of the data. My research focuses on health equity in the space of eye care and vision health. For orientation, health equity is when everyone can obtain optimal health regardless of race, ethnicity, gender, income level, or other social factors that create barriers to health. These are two graphics that are used to explain health equity. The one at the top is from the Robert Wood Johnson Foundation and highlights that not everyone needs the same kind of support. The bottom apple tree illustration has been used to illustrate the distinction between inequality and equity. Next slide. Social determinants of health are estimated to account for 80 to 90% of modifiable health factors, while the medical care a patient receives only accounts for about 10 to 20%. While healthcare providers strive to provide excellent care for patients, unfortunately, given what is understood about social determinants of health and how they impact both patients' lives and health, solely providing exceptional personalized care will not achieve equity in health outcomes. Thus, it is imperative to expand the healthcare team and breadth of research. Next slide. Social determinants of health are the conditions and the environments where people are born, live, learn, work, play, and worship, and age that affect health functioning and quality of life outcomes and risks. This graphic comes from Healthy People 2030 and outlines the 5 critical domains of social determinants of health, which have been identified. These include education access and quality, healthcare access and quality, economic stability, social and community context, and neighborhood and built environment. Examples of education access and quality include literacy and higher education. Healthcare access and quality examples include healthcare coverage and quality of care. Neighborhood and built environment examples include housing, transportation, and safety. Social and community context examples are stress, discrimination, and support systems. And economic stability examples include employment, income, and medical bills. Social determinants of health also contribute to health disparities. Next slide. Health disparities are a health difference based on one or more health outcomes that adversely affect defined populations. These populations have been outlined by the National Institute on Minority Health and Health Disparities and include racial and ethnic minority groups, underserved rural populations, persons with less privilege from any racial or ethnic group, persons with low incomes, sexual and gender minority groups, and last month, it has now included the designation of individuals with disabilities. Research in this area examines adverse health outcomes for these populations and what my research focuses on. Next slide. The studies I will be sharing with you today focus on the neighborhood and built environment domain of the social determinants of health. Next slide. First, I will discuss a past policy that has implications for present-day measures of visual impairment and blindness. Next slide. My first study using a large data set is entitled Seeing Red, Associations Between Historical Redlining and Present-Day Visual Impairment and Blindness. Next slide. Discriminatory housing policies and persistent residential segregation have impacted education, wealth, and health in the United States. One such historical residential housing policy is redlining. In 1933, the Homeowners Loan Act was enacted and the Homeowners Loan Corporation, or the HOLC, was established to combat the negative effects of the Great Depression by refinancing mortgages at low rates. HOLC maps used a system to grade neighborhoods according to their mortgage investment risk. These HOLC maps used the following systems to delineate which neighborhoods had the lowest and highest mortgage investment risks. Letter A, or green, was best. Letter B, blue, was still desirable. Letter C, yellow, was definitely declining. And letter D, red, was hazardous. Neighborhoods with high proportion of Black individuals were outlined in red. This act of drawing a red line around these majority Black neighborhoods begat the term redlining. People living in previously redlined neighborhoods are more likely to live in areas with high crime, poor environmental quality, low educational attainment, poor economic opportunities, and poor health outcomes. Recent research has associated redlining with present-day health outcomes, including asthma ER visits, diabetes, hypertension, and stroke. Next slide. Redlining has previously not been researched within eye health outcomes, but as previously mentioned, is associated with chronic diseases that increase individuals' risks for vision-threatening eye diseases. The purpose of this study was to assess if there is a greater estimated percentage of people who are blind or have serious difficulty seeing, even when wearing glasses, in census tracts with worse historical redlining scores as compared to census tracts with better redlining scores. Next slide. Redlining scores for our study were obtained from the Open Inter-University Consortium for Political and Social Research, or Open ICPSR, using version 2 for 2010 census tracts. Mir and colleagues at the University of Michigan School of Public Health found that census tracts were not always composed of areas with only one redlining grade. So the grades were converted to numeric values and aggregated over a census tract based on the distribution of grades within. Redlining scores were calculated by using the sum proportion of redlining grades and multiplied by a weighted factor that was based on the area within each individual census tract. Census tracts with less than 20% of the area not graded were excluded. These redlining scores ranged from 1 to 4, with higher scores indicating that larger proportions of the territory had worse grades. Demographic factors were also obtained from Policy Map, which used the 2010 to 2014 5-year estimates from the American Community Survey data for the 2010 census tracts as well. These variables included median age, the percentage of residents that were female, the percentage of residents that identified as a person of color, which included anyone who identified as Hispanic or Latino, multiracial, or any other race other than white. And then we also obtained the percentage of residents that identified as Black or African American, but this did not include multiracial, Black, or African American. The outcome variable of interest was visual impairment and blindness, which is defined by the American Community Survey by the following question. Is this person blind, or do they have serious difficulty seeing, even when wearing glasses? Next slide. Census tracts that had missing data for any of the variables of interest or that had a large margin of error of greater than 15% of the estimate were excluded. Demographic and health estimates were summarized with descriptive statistics over census tracts and investigated for distributional properties and outliers with histograms. The distribution of redlining scores across tracts were categorized into quartiles. Kruskal-Wallis tests were performed to test for differences between the quartiles with respect to demographic makeup, visual impairment and blindness, and population size. Significant results were followed by post-hoc pairwise comparisons using home-adjusted Dunn's tests. Logistic regression models were used to estimate the effect of redlining on the probability of visual impairment and blindness in the unadjusted models, and the models adjusted in the adjusted models, neighborhood measures were adjusted for. Logistic regression models that were adjusted for included demographic makeup, population per thousand, and state. Separate models were run to adjust for estimates of people of color and the residents that identified as Black and African American. Next slide. Significant differences between census tracts were observed in redlining quartiles as seen in Table 1. Specifically, median age decreased across the quartiles. So census tracts in the worst redlining quartile had significantly younger residents than in each of the other quartiles. The percentage of individuals that identified as a person of color and the percentage of Black and African American residents increased across quartiles, such that in census tracts in redlining quartile 4, there was significantly higher proportion of people of color and Black and African American residents than each of the other quartiles. The percentage of female residents decreased with higher redlining scores, and visual impairment and blindness significantly increased with higher redlining scores, such that quartile 4 had the highest percentage of residents with visual impairment and blindness. Lastly, population size per thousand decreased with higher redlining scores. Next slide. This figure shows the aggregated redlining score for one example of Detroit, Michigan on the left, and on the right, this is the visual impairment and blindness quartiles for Detroit, Michigan. Some previously redlined areas have been changed by gentrification, so these neighborhoods may have an increase in white individuals with higher education and income. This could be one potential reason why some areas in this figure have less correlation. This is just one city example using ArcGIS, but demonstrates the individual census tract data looking at the exposure and outcome. Next slide. Okay. Logistic regression models assessing the association between redlining score and visual impairment and blindness are presented in Table 3. In the univariate model, a 1-unit increase or worsening in redlining score was associated with an 18% increased odds of visual impairment and blindness. After adjustment for census tract estimates of people of color, age, sex, population size, and state, worse redlining score remains associated with statistically significance, such that there was increased odds of visual impairment and blindness. For example, a 1-unit increase in redlining score was associated with a 13% increased odds of visual impairment and blindness. Similar results were observed in the logistic regression model adjusting for the estimated percentage of Black and African American residents, such that a 1-unit increase in redlining score was associated with an 18% increased odds of visual impairment and blindness. Next slide. Though redlining became illegal in 1968 through the Fair Housing Act, communities residing in previously redlined neighborhoods feel the health implication of this policy to this day. This research has demonstrated that people living in areas with worse redlining scores may experience worse visual impairment and blindness. Policy change is essential to ensure that census tracts with worse redlining scores and neighborhoods with higher proportions of visual impairment and blindness have the necessary resources to carry out interventions to mitigate preventable visual impairment and blindness. In closing, from the findings for this research, I think it is important to highlight that it may be uncomfortable to talk about these situations at times, but it must be done to ensure that health equity can be achieved for health outcomes. Next slide. Next, I will discuss present measures of neighborhood inequity and visual impairment and blindness. Next slide. My second study focuses on present-day measures of neighborhood inequity, including residential segregation, income inequality, and persistent poverty. Next slide. The literature on neighborhood level measures of inequity and health outcomes has reported an association with increased segregation in preterm birth and hypertension, persistent poverty with cancer, and income inequality with diabetes. Additional research is needed in the space of eye care and vision health. Previous research has established an association of area deprivation with visual acuity in both diabetic retinopathy and glaucoma screening. Next slide. This study aims to assess the link between current day neighborhood measures of segregation, income inequality, and persistent poverty and self-reported visual impairment and blindness. Next slide. The outcome variable of interest on the left was visual impairment and blindness and was obtained from the 2012 to 2016 American Community Survey data, which uses the same question that we assessed in the redlining study. Again, we used Detroit as an example for this figure. The Thiel's H index was obtained for 2010 And the Thiel's H index is a measure of neighborhood racial segregation ranging from 0 to 1, where increasing values represent a more segregated neighborhood. This metric is calculated by policy map utilizing the multi-group entropy index. Next slide. The Gini index was obtained for 2012 to 2016 utilizing the American Community Survey. And the Gini index is the estimated inequality of household income and ranges from 0 to 1, where 0 indicates perfect equality. Next slide. We also assessed persistent poverty, which was obtained for the 2010 census tracts. And persistent poverty of a census tract is when 20% or more of the population within a census tract has been living in poverty for over 30 years. This metric was also created by Policy Map using Brown University's longitudinal tract database, as well as poverty data from the American Community Survey. Next slide. Measures of neighborhood demographics were on average 0.22 for the Thiel's H index, 0.42 for the Gini index, and overall 8.4% of census tracts had persistent poverty. Census tracts had a mean median age of about 39 years of age. Population size had an average about 4,300, and the average percentage of people of color per census tract was around 38.2%, and the average percentage of the female population was about 51%. Census tract visual impairment blindness was significantly associated with all measures of census tract inequity and census tract demographics. Specifically, visual impairment blindness significantly increased with higher Thiel's H index and Gini index scores, and in census tracts with persistent poverty. In addition, increased visual impairment and blindness was associated with an increase in all census tract demographic factors, except for population size, where there was a decrease in population size when visual impairment and blindness increased. Similar results were seen for the sensitivity analysis we conducted, which eliminated census tracts with low reliability. Next slide. After adjusting for census tract estimates of age, sex, people of color, percentage, and the population size, as well as state, all measures of neighborhood inequity remain statistically significantly associated with visual impairment and blindness, such that a 0.1 unit increase in the Thiel's H index was associated with a 14.4 increased odds of visual impairment and blindness. In the combined multivariable model, including the Thiel's H index, the Gini index, and persistent poverty, a 0.1 unit increase in the Thiel's H index was associated with a 12.6% increased odds of reporting visual impairment and blindness. Next slide. In the adjusted model, a 0.1 unit increase in the Gini index was associated with a 15% increased odds of visual impairment and blindness. And then looking at the combined multivariable model, a 0.1 unit increase in the Gini index was associated with a 10.6 increased odds of visual impairment and blindness. Next slide. And finally, living in a census tract with persistent poverty was associated with a 35.6 increased odds of visual impairment and blindness in the multivariate model. And then in the combined multivariable model, living in a census tract with persistent poverty was associated with a 21.1% increased odds of visual impairment and blindness. For all measures, similar results were seen in the sensitivity analysis. Next slide. Our study suggests structural social inequity may drive poor visual outcomes in patients living in census tracts with greater inequity. Understanding the structural systems of historical and present-day inequity allows for more whole person care. These associations can inform future policy work to promote systemic investment and targeted interventions in these high-risk census tracts. Some potential policy solutions include advocacy for addressing social risk factors, increased incentives to open eye care practices in medically underserved census tracts, such as improved Medicaid reimbursement, and additional clinical resources to support patients who live in high-risk census tracts who present for care. Next slide. That I want to conclude with my references for project 1. Next slide. And my references for project 2. Next slide. I also want to take this time to thank my collaborators on these research projects from the University of Utah, the University of Michigan, Loma Linda University, and Newark. Next slide. I can take any questions at the end of this seminar, but if you have any additional questions, please feel free to email me. I also have X, formerly Twitter, and my handle is iEpi. Thank you all for your time today. And with that, I believe I'm passing it back to Dr. Newman-Casey.
Well, thank you so much, Dr. Hicks, for that excellent presentation. I can't wait to hear people's questions and for you to entertain people's questions and answer them at the end of the session. But now we get to hear from Mikaelah Johnson-Griggs, who is one of our star medical students. She is currently a third-year medical student, but joined our lab between her first and second year of medical school as really chosen in a very prestigious program that the Kellogg Eye Center is running called the Health Equity and Ophthalmology Summer Research Program. And we were very honored to have her join our lab. Her enthusiasm is amazing. Her passion for this topic is wonderful. And she is going to talk about the relationship between unstable housing and food insecurity and vision status in a screening program that we're running as a pilot program for the CDC to see if we could come up with infrastructure and ideas of how to engage people at high risk of eye disease in screening and eye care. So thank you very much, Mikaelah, and I'm going to let you take it away.
Awesome. Thank you so much for the great introduction. As just mentioned, my name is Mikaelah, and I feel really fortunate today to be talking about our lab's research on the relationship between unstable housing, food insecurity, and vision status in the Michigan Screening and Intervention for Glaucoma and Eye Health through Telemedicine, or the MySight program. And I have no financial disclosures. And so, unfortunately, we all may be aware of the fact that visual impairment disproportionately impacts those experiencing poverty and of racial and ethnic minority groups. We often also see in these groups that there's a decreased eye care utilization due to many barriers, which can be cost, unreliable transportation to and from appointments, a lack of trust with providers. The list goes on and on. And unfortunately, in these groups, the visual impairment that we're seeing are the 5 leading causes of blindness and visual impairment within the United States. And in no particular order, you can see those on the slide: glaucoma, cataracts, or undercorrected refractive error, macular degeneration, and diabetic retinopathy. And you may be wondering, why are we seeing these things in these groups when these diseases are often treatable or preventable? And so in part, this can be attributed to social determinants of health, social risk factors, and social needs. And so I think Dr. Hicks did a great job explaining social determinants of health, so I won't belabor the point, but it is a population level measurement, and it's essentially showing how society level health is impacted by where people work, age, play, worship, and grow. So the SDOH aren't inherently positive or negative things. They simply are what they are. Social risk factors, on the other hand, are how the SDOH impact an individual on the individual level. And so these things may be positive or negative. For example, in this study, we're looking at food insecurity and housing instability. So food insecurity is the unreliable or limited means to attain adequate quantities of food. We can see how that can be negative. Similarly, housing instability is the concern or lack of ongoing safe and unreliable shelter. And so we can see negative as well. One step further, we can look at social needs, and that is what an individual determines to be their most pressing need at the time. And so the MySight program looked at these definitions and decided that they wanted to utilize telemedicine-based eye care to improve ophthalmic pathology detection in populations at higher risk of disease, such as experiencing food insecurity or unstable housing. And so our objective for this project in particular was to assess if food and housing insecure MySight participants had an increased prevalence of visual impairment, worse presenting visual acuity, and a higher prevalence of the 5 leading causes of blindness and visual impairment. And so you may be wondering, how did we actually do this? How did we measure this? And so this kind of shows how a person would go through the clinic. First, they would have an informed consent and complete a socio-demographic survey on their own in a room. We would give them an iPad to do these things. And then next, we would have glaucoma and eye disease screening from an ophthalmic technician at the FQHC, which is a federally qualified health center, which is located in Flint, Michigan, or a free clinic in Ypsilanti, Michigan. Once that was the data was taken, a remote ophthalmologist at Kellogg would then review the testing, review the images of the retina that were taken, and also look at patient information and relay their results and their conclusions on this patient's diagnosis back to the clinic staff at these two sites. This would often result in either someone telling that they were okay, being referred to see their existing ophthalmologist, or they could come into a free clinic spot or time for specialized ophthalmic care here at Kellogg. We also provided free glasses as well. And so what did we find? In the first year cohort at these two separate locations, we had 1,171 enrolled participants. 34% of these participants were at the free clinic and 66% were at the FQHC in Flint. On average, participants were 55 years old, 62% were female, 54% were Black, 34% were white, and 10% were Latinx. 50% reported less than 20K or 20,000 annual household income, and 20% reported no medical insurance. I'm sure you're wondering where the meat and potatoes, what did we find in response to food insecurity and housing instability? So we found that 3% self-identified as facing housing instability. We found that 29% identified as having food insecurity, and 2% identified as facing both of these social risk factors. And so what was statistically significant? We found a statistical significance with unstable housing with 3 different ophthalmic pathologies, being presenting VA or visual acuity, undercorrected refractive error, and a visual impairment being defined as the better eye being worse than 20/40. And so we'll unpack this a little bit further in the upcoming slides. And so on the right, just to have everybody oriented, I'm sure when you've gone to your doctor's office or your ophthalmologist or your optometrist, they've had you kind of cover your eyes and read the chart. And so I just wanted everyone to kind of have a good baseline of what we're referring to when I talk about Snellen lines. And so a Snellen line in this response or in respective to this data is going to be a line up. And so when you look at the left at the figure, we're going to see some bolded values. Those are the statistically significant findings. So on the top line, in the setting of housing insecurity, if you also identified with food insecurity, you had a 0.15 logmar worse or 2 Snellen line poor, so larger letters, scoring. Directly below that, if you were insecure in both food and housing, you had a 0.15 logmar worse or 2 Snellen line poor, presenting VA. Further down, you see in the setting of food security and housing insecurity, you had a 0.19 logmar or 3 Snellen line poor, presenting VA, compared to food insecurity and housing security. And then in the setting of food security, if you also identified with housing insecurity, you had a 0.19 logmar worse or 3 Snellen line poor, presenting VA. And so now we're looking at the association between both housing and food insecurity and undercorrected refractive error on the left and visual impairment on the right. I want you to first look to the left. The 2 bolded values are statistically significant. So in the setting of housing insecurity, if you also identified with food insecurity, you had a 5.86 greater odds of presenting with undercorrected refractive error. Below that, in the setting of insecurity of both social risk factors, a 4.76 greater odds of undercorrected refractive error compared to those that secure in both. Now, if we transition to the right, we will be looking at visual impairment, once again being defined as the better eye being worse than 20/40. You'll first see that in the setting of housing insecurity. If you also had food insecurity, you get a 4.35 greater odds of presenting with visual impairment. And directly below that, in the setting of insecurity of both social risk factors, we had a 3.9 increased odds of visual impairment compared to those that are secure in both. And so I know I just told you a lot of numbers, and I'm sure you're wondering, how am I supposed to interpret this and what does this mean? So I want you to go back into the deep recesses of your mind, either in high school, college, when you first learned about Maslow's hierarchy. And essentially, it's a pyramid as a hierarchical system of how you pursue your needs. At the base, we have physiological needs, such as food, water, warmth, and shelter. If you cannot achieve those bottom basic needs, you then are unable to pursue the next level of needs. So the higher one of safety needs, which includes security, safety, and healthcare pursuit. And so I think it's really important that when we consider providing healthcare to patients, we need to understand where they're at and where their time expenditure is being allocated. And so this is important for physicians alike, as well as other people involved in the healthcare system and policy system as well, to understand where people are spending their energy. I've included on the slide some of the national and micro community level things that people are doing to provide and ensure basic needs for folks. This can include the Supplemental Nutrition Assistance Program called SNAP, also known as EBT, and Medicaid. On a micro level, whole person care is a system that provides medical, dental, as well as food banks and laundry at the free clinic. And so that's a micro level of being able to provide people their ability to have consistent basic needs being met. And so in conclusion, our project did have some limitations. We did have a lack of reliability in neighborhood ADI or area deprivation index among our federally qualified health center participants. And while this is a limitation, it also is incredibly helpful because this project is looking specifically at those of higher risk. Secondly, we had a higher food insecure percentage of participants at the free clinic. As I just mentioned, whole person care includes a food bank. And so we suspect that likely a lot of people who are getting their care at that free clinic are likely often utilizing that food bank access as well. And lastly, food and housing insecurity status depended on self-identification. And so with that, there comes a risk of self-desirability bias. We did try to mitigate this by having participants fill out these surveys on their own, so they didn't feel like we were imposing them or having any need to impress us or feel embarrassed or any other sort of emotion when filling out their sociodemographic information. Lastly, in terms of next steps and future directions, we'd like to encourage policy level changes to address the SDOH disparities because this is a population level issue and thus a population level solution is going to be required. If we want to look a little bit more downstream, we would consider placing eye health programs in homeless shelters or those experiencing houselessness, especially because their social needs are going to be more pressing towards housing. And we recognized in this study that they were the ones that had the statistically significant increase of ophthalmic pathology. These are my references. And I'd just like to acknowledge the incredible team who's really helped me develop my research sense and also helped me express this extreme interest I have in health disparity and inequities work. Once again, thank you for letting me present today, and I'm happy to answer any questions anyone may have.
Well, thank you so much, Mikaelah, for presenting your wonderful work looking at these social risk factors for presenting with poor vision. And, I think it was fascinating that you found that people really were coming in without having access to glasses. People who were having, reporting unstable housing were much more likely to come in just not having access to glasses and coming in not being able to see because they couldn't get glasses or because glasses wasn't the first, thing on their mind to take care of. And I think you highlighted that so nicely, that it's hard to have glasses be a priority when you're having trouble finding shelter. I know we've had some really wonderful questions come in, and I think if it's all right, Dr. Hicks, I think we had some wonderful questions come in for you, and then Mikaelah for you too. But Dr. Hicks, we'll start with yours. There was a question about thinking through aspects of the social and physical environment that might better support people with vision disabilities who live in areas that have been historically marginalized, in areas with high levels of poverty. And I think it's that's a question of what to do once someone already has vision impairment and blindness. And then I think on the flip side, we'd also like to hear your thoughts on kind of the policy things you'd like to see change for how to potentially address some of these things before they leave more people with vision impairment and blindness.
Yeah, that's a great question. I think, one great step forward now is with the NIH being able to provide more research now that individuals with disabilities has been identified as a group within disparities research. And so definitely we always need the research to back, what our thoughts are on and making advances in this area, but making sure within the communities for those who already have visual impairment and blindness, making sure, that infrastructure and transportation are accessible, making public spaces and buildings and transportation accessible for individuals with disability, but obviously in this case, those with visual impairment and blindness, and also making sure that the community is accessible. I wish I would have used the other figure from the Robert Wood Johnson Foundation, because they recently have updated, their health disparities figure, but there's a nice one that they show where there's a crosswalk, and there's one that's not accessible versus the one that's accessible, and the one that is accessible, now has like a ramp for individuals, as well as a talking crosswalk that would help individuals with visual impairment blindness. I think another aspect too is ensuring accessible when we're thinking about neighborhood and built environment, that also includes housing. So making sure that individuals with visual impairment and blindness are able to access accessible housing. And this is, going to be their safe space in which they live, and make sure that that the housing that is offered for those individuals are accessible and meeting their needs. I'm thinking to how to, I think the second part was in terms of preventing visual impairment blindness within communities with less legal resources. I think one area of interest is through, federally qualified health centers. And so these are medically underserved areas, and currently in FQHCs, Mikaelah had mentioned the one that the MySite study collaborates with in Flint, and that's a previously redlined area. But within FQHCs, currently vision care is underutilized, and I think the FQHCs are in a position to expand coverage to individuals who may not be able to access care normally within their community. But a major barrier to doing this is in opening clinics or expanding the FQHC's ability to offer vision care services is, the financial reality of it all. And so there is reduced compensation for patients that have Medicaid compared to Medicare, or those who are privately insured patients. And so a potential policy solution is expanding Medicaid disproportionate share hospital programs to support both clinic growth, so offering those vision care services within those FQHCs, but it also will help to close that compensation gap. And potential policies could, increase Medicaid rates nationally to meet what is currently being offered by Medicare levels.
Thank you. I think you highlighted some really important topics, especially in specialty care, where there's so much diagnostic equipment that's needed to carry out these kinds of screenings and identification of disease early in the process. And then treatment, of course, is also expensive and oftentimes requires monitoring by specialists who may be, there just might be fewer of them in an area, and they may not be co-located with a patient. And telemedicine is not currently reimbursed at any kind of a sustainable level. And there's this additional issue where Medicaid payment levels are determined by state. It's not federally determined like Medicare is. And so the variability is enormous. And so, people's ability to provide care varies by state. And that is, leads to inequity in the US. And I think you just brought up some really great points also about making places accessible. I mean, the Americans with Disabilities Act was really landmark in starting some of this, and hopefully, that work will be continued, and investment in places that have not been invested in will happen, making things more accessible. There's also the Michigan Bureau for the Blind is where people, when they're actually blind, we were talking about people with visual impairment, so where you're not legal to drive, but you're still not blind. And that's what Patrice and Mikaelah are both talking about. So it's an in-between state. We know that affects people a lot who are working and makes it a lot harder to work when you can't see well, but you don't qualify for services from the Bureau for the Blind. That's like a different kind of, it's a smaller percentage of people. And once you qualify for those kinds of services, then, you end up getting things like a white cane and training with how to use a seeing eye dog and other sorts of transportation assistance, but that's for a very small percentage of the people who are kind of struggling to see on a daily basis. Thank you, Patrice. I'm wondering, Mikaelah, if we could also get your opinion on what you think some policy level changes might be that you'd like to see to help address what we identified as an upstream factor for presenting with visual impairment just due to not having glasses. I know you mentioned that, maybe placing more eye care in homeless shelters or placing like access to glasses in homeless shelters might be one way to tackle the immediate needs. But what are some of your ideas about some of the wider societal issues in the US that are leading to all of this homelessness and housing instability?
Yeah, I think one of the major things that I emphasized is essentially putting these clinics or free eye care access directly in or nearby those experiencing houselessness. But I think on a larger scale, experiencing houselessness is a nationwide issue. And I think something that we could do to help alleviate that is ensure that there's equitable, affordable housing. Nationwide, I think that can be instituted by ensuring that every new apartment building has to have so many equitable, accessible apartments, and kind of like boundaries within that in terms of like city architectural planning. That's a little bit outside of my forte, but I think that's something that we can institute, or that theoretically is being instituted currently, but not actually being affordable for people. I know even locally in Ann Arbor, we have a lot of people experiencing houselessness, and yet they're unable to afford an apartment or a studio because it can be anywhere from $2,000 to $3,000 a month. And that's not affordable for most people. And so if there's a way that we can have equitable access where people have to have housing for people, and it's not an option, no matter what type of housing it is, whether it's an apartment building, townhouse area, I think we're going to be able to mitigate one of those basic needs that I talked about in terms of housing, warmth. And so then people can pursue their safety needs, such as having a community, then having even the opportunity to then pursue healthcare, and just having the space in their mind and their brains to talk about some of the things that we talked about, especially vision, as it seems to be one of the things that people pursue help with only when it's to the point of no return, or when it's so exacerbated that there's limited things that we can do to fix that.
Thank you, Mikaelah. And I think I just want to point out in your work, what was really interesting to me is that we didn't find an association between housing insecurity and the prevalence of eye disease. We found the association between presenting with visual impairment, which was mostly due to not having glasses. So it is true that some of that visual impairment we couldn't do anything about and people are presenting too late, but 80% of it we could. So that was really inspiring. And I'm wondering also, Dr. Mikaelah, if you can maybe comment on some of these issues, because obviously we're coming at this from an eye care perspective where we're looking at things and saying, this is really crummy that we're finding all this, increase in visual impairment and blindness in neighborhoods with more segregation, in neighborhoods with more persistent poverty, and then among people, particularly who are experiencing homelessness or housing insecurity. And so maybe you could comment. I mean, that's one of the reasons we were so honored to be here today, is to hear your perspective on what is happening in the US in terms of movement in this space. What are the current policy levers or policy pushes to improve housing affordability and housing stability, like Mikaelah was saying? And I'm not sure if Dr. Mikaelah, you might not be able to hear me, so I guess I'm going to flip the question back to Dr. Hicks. And you talked about a little bit of the disparities in Medicaid and Medicare payment, and you also mentioned this issue with DISH payments. Maybe you can expand a little bit on what you mean about DISH payments and what they are. I don't know if the majority of people here are familiar with how hospitals are reimbursed for care for people either with Medicaid or for people who don't have insurance. But maybe if you could tell a little bit more about what you meant by that idea.
Yes, so currently in terms of ophthalmology care, Medicare is reimbursing for services that patients receive. So any ophthalmology services at a higher rate than what hospitals are reimbursed for patients that are being seen with Medicaid. And so the Medicaid disproportionate share hospital program can help to kind of cover that gap, that difference, or the expansion even in Medicaid rates. If they go up, they can be met at that Medicare level. So currently Medicare is paying hospitals more, and so there are hospitals or clinics that are more likely to take patients that are, because they're being reimbursed for these services at a higher rate. And so this can limit the services or the locations that Medicaid patients can go to, because their insurance is not accepted at those facilities. And so clinics or hospitals may be more inclined to take patients with Medicaid if that compensation gap is rectified, and patients are being Medicaid patients' services are being reimbursed at that same level as Medicare patients.
Yes, Dr. Hicks, thank you. I think that's something that a lot of people would like to see. They would like to see both Medicaid expand. So when the Affordable Care Act happened and expanded, and I think now we have 41 states who have expanded Medicare coverage to 138% of the federal poverty level. That really increased the number of people who had insurance, and that was wonderful. So expanding access to insurance is the first step. But then when Medicaid pays a half to 2/3 of what Medicare pays, then the people who accept all Medicaid patients, such as the federally qualified health centers or academic medical centers, generally accept Medicaid as well, but also think about that in terms of their greater finances, making sure that they're having some Medicaid patients, a lot more privately insured patients. And these dish supplements that came from the government were meant to mitigate that kind of gap in payment to academic medical centers, particularly. And there's other modes of kind of dealing with the fact that people can't cover their costs for providing care for Medicaid patients, such as FQHCs in the state of Michigan. Every year at the end of the year, the FQHCs go to Congress and ask if they can cancel out their debt for the year, because they can't afford to pay all the people who work there just with the collections that they're getting from Medicaid. So this is a problem in terms of accessing specialty care on the medical side that people have been generally disinterested in fixing from a policy perspective, because Medicaid is governed by, separately by each state. So yes, and Dr. Mikaelah, we had a question for you. We were just talking about how we were so glad to be here because we see things from the medical perspective, but we're finding all of these neighborhood level factors that are really impacting how people are presenting to us clinically, and how visual impairment and blindness is manifesting in all of these different neighborhoods. And we were wondering, from your perspective, like, what policy levers do you see? What up and coming policy changes might we find, or might we be supportive of, to improve, as Mikaelah was saying, housing affordability and access?
Yes, and I'm sorry, I just stepped off for 1 second, and that's when you caught me. But
no worries.
I mean, we recently, with Dr. Amy Schultz and a doctoral student, we did some work on how redlining can impact the disinvestment, like continued disinvestment in neighborhoods. And some of the policies that come about from that could be things as we talk about areas of more focus on addressing housing discrimination and access to housing, affordable housing. I know, as Patrice mentioned, the 1968 Fair Housing Act was supposed to stop housing discrimination, and it did at at a more overt level, but there's still subtle examples of it. And we've done research examining how there still exists discrimination at the time of home ownership, but then also at the time of renting. And so addressing some of those issues through more sources and resources and awareness around that. But also, I know we haven't had a time to talk about this, but there's a growing amount of conversation around reparations and what that looks like in terms of what happens to these neighborhoods that have been historically disinvested. What is our responsibility to these, but not just talking about the red line neighborhoods, but also the issues of redistributing wealth from those green line neighborhoods or areas that weren't redlined onto other areas. So what does that distribution of power and wealth look like over time? So that's my input, and I do see we're at the end of time. So I did want to maybe end on that note and thank you, Dr. Newman-Casey, for moderating the panel, and Dr. Hicks and Mikaelah for your wonderful presentations. We don't usually get to talk about specific health outcomes. So to me, connecting it to eye health, and Patrice, I've been learning from your work over the last year, and it's just so fascinating to see those links where it has been more obvious in other areas. So that has been really great. And so today marks our first event of 2023-2024 of the Housing Solutions Speaker Series, and we're so happy to have been able to highlight the variety of housing research and practices and their connections to health and health equity throughout these events. We are grateful to our partners who have helped promote this event series, especially Poverty Solutions and the School of Public Health. If you have not done so, please keep in touch with us by signing up for our newsletter and continue to look out for more events and research from us. We look forward to seeing you this spring during our next talk. And again, thank you so much to our speakers. And as Malika said, we will be sharing our recording on this soon. Thank you all. Thank you so much.